I'm a practicing psychiatrist, and my background is in addiction psychiatry, which means I did a special fellowship training and board certified in that. But more interestingly for me, my background was in researching marijuana addiction. We did neuroimaging research at Penn, where we study all types of addiction. And when I was doing my fellowship, NIDA, under the leadership of Dr. Volkow, who's currently the director of NIDA, started to fund very heavily research looking into treatment for marijuana addiction. It is the most widely used substance in the world. It is addictive, and she was hoping that we would come up with some treatments. To do that, she gave us funding to look at the brain. So that's how I started to get interested in the field. Currently, I'm a practicing psychiatrist in the Jenkintown area, where I treat people for a variety of psychiatric conditions, including addiction disorders. So some of the research I'm going to show you will be research that I've done. Our group published the first neuroimaging study showing the signature of marijuana addiction in the brain. But I'm going to talk about research of other people as well. So first, disclosures. So I have no relevant financial relationships to disclose. I've been very careful not to affiliate with any kind of industry, marijuana industry, so that I could be impartial when giving presentations like this. I will include off-label use of FDA-approved medications, because we've been experimenting in treating cannabis dependence, marijuana dependence, by using medications that are FDA-approved for other conditions. So I'll talk about that a little bit. Legalization of marijuana or cannabis will not be discussed in this talk beyond the next two slides. But this talk will focus on the medicalization of marijuana or cannabis and cannabinoids. So it's not going to be about legalization, it's going to be about medicalization. So I have two slides on legalization. So this is the Canadian perspective on legalization of marijuana. And this is from 2017 May, interview with the Prime Minister of Canada in Bloomberg Business Week. So he says, the reason we are choosing to legalize and control marijuana in Canada is because the current system is not protecting our kids. Right now, it's easier for an underage Canadian, a teenager, to buy a joint than it is for them to get their hands on a bottle of beer. So whatever you may think about relative harms of marijuana versus alcohol or cigarettes, marijuana's not good for the developing brain. This is something that the Prime Minister is saying. He's not a scientist, but he's referencing science here. It's not good for our kids. We need to do a better job making it more difficult, at least as difficult as it is to access alcohol. So looking at it from a public health and safety standpoint, as opposed to other places that are legalizing it for commercial reasons. And then their main issue right now is how to protect kids, so they're going to legalize cannabis in order to get the kids away from it. So that's the Canadian. Now, of course, they went through with this. This was about a year ago. And so what he was really talking about is something like the Tobacco Control Act in the US. If you remember, around 2009, the FDA started to really regulate tobacco in a much different way than it had previously. So that's what Canada's doing with cannabis, and that's why they're legalizing it. So I'm going to move away from legalization, and I'm going to talk about learning objectives here. So objective number one, which is Act 16, marijuana in Pennsylvania, and the severe medical conditions that are covered under that act, will be covered by my co-presenter, Mr. Seth. I will cover the other two learning objectives that is going to really focus on helping you talk to your clients about marijuana use, coordinating care among various providers, tracking measurable treatment goals and outcomes, and how to give your clients information about marijuana intoxication, marijuana addiction, and available treatments. Okay, so in summary, if you leave the room you're basically gonna get this information, so if you fall asleep or leave the room early. So marijuana cannabis has identifiable biological targets in the central nervous system. The FDA has licensed 4 drugs, 4 medications, based on or derived from cannabinoids. And these medications have been studied for additional clinical uses. Act 16 is the act in Pennsylvania that has legalized the use of non-FDA approved cannabis compounds for treatment of serious medical conditions. So this is the act that has medicalized marijuana. And with this in mind, it's important to take into account that cannabis has strong addictive potential. Cannabis use disorder is associated with specific behavioral manifestations in adults. In adolescents, it's associated with significant neurocognitive and behavioral changes. And that there are specific targets, or there are specific interventions that can treat cannabis use disorder. All right, so let's get to the actual talk. So these are the 4 medications that are now available in the U.S. So the U.S. FDA has licensed 4 medications based on cannabinoids. The oldest one is dronabinol. It's generic. This is the one that we used at Penn in the treatment study when we were trying to treat marijuana-addicted patients. They were coming in saying, I can't get off this stuff, get me off. So we used agonist treatment like we do for nicotine. Instead of giving them a nicotine patch or Suboxone for opiates, we gave them dronabinol, which is oral THC. That's all it is. It's pure THC. It's synthetically manufactured, comes in a pill. The largest pill is 10 milligrams. And we gave them pretty big doses to try to help them come off the smoked marijuana. It was not successful. They could not quit. And the doses we're giving were so high, we had to have special FDA phone conferences because we requested an IND, which is permission from the FDA to give large doses of an FDA-approved medication for a different reason. And they were concerned that we were going to totally over-medicate these patients, and it wasn't safe. So we had to really have a lot of conference calls, reassure them we're going to be putting all kinds of safety measures in place. And the patients they were like, yeah, I take the medicine, but it doesn't do anything for me. I just want to smoke. So it didn't help them. But it is FDA approved for chemotherapy associated nausea and to stimulate appetite in people who are developing wasting syndrome with AIDS. So they have no appetite, they can't eat, they lose a lot of weight, and this helps them, the THC helps them regain weight and helps to reduce their nausea. Dronabinol was also approved as a liquid. So this is a pill, and this is the liquid. Both of these is the same substance. They are Schedule 3. So just to give you a sense of schedule, so 2 is our most addictive, medically beneficial substance. So like, for example, opiates, all the prescription opiates, they're all Schedule 2. Suboxone is Schedule 3. So this is considered, you would think of it as addictive as Suboxone. All the benzodiazepines are Schedule 4. So it's more addictive than a benzodiazepine, less addictive than an opiate. That's where THC fits in, not marijuana, THC. The other substance, the other medication that's approved by the FDA is nabilone. So nabilone is a THC lookalike. It looks almost exactly like THC. That's what was developed for the same exact indications, but there's a slight difference in the molecule, and that slight difference makes it much more potent, and that's why it's a Schedule 2. It's as addictive as an opiate, more addictive than the regular kind of THC. So nabilone is also prescribed for, FDA approved for chemotherapy-induced nausea and vomiting and wasting syndrome. Okay, same indication. When nabilone was used in New York by the New York group that studies marijuana addiction, it did work. Dronabinol did not work, but nabilone did help patients come off marijuana. So we needed something stronger to help them come off marijuana. And I'll show you that at the end. Both dronabinol and nabilone are given orally. So they're not smoked, they're not vaporized, they're swallowed. So they have a slow onset of action. And again, this is like giving methadone, oral methadone instead of heroin, right? So you replace something that goes right into your vein or a nicotine patch instead of smoking a cigarette. So you want a slow onset of action, you want to block the receptors if you're going to use something like that. In response to an urgent need expressed by parents of children with intractable epilepsy, the FDA started investigational trials of CBD oil, and just recently approved in 2018, they have approved it, and it's called Epidiolex, or that's how I pronounce it. It's basically pure CBD, and it's approved specifically for seizures, these specific seizures, Dravet and Lennox-Gastaut syndromes. And this will likely be on schedule. So they already have the prescriber information. If you guys want to Google it, you can find it online. And they did all the studies that show, that look at the addictive potential of CBD in those studies. And they didn't find any addictive potential, so they're waiting for the DEA to give the final ruling, but it's probably going to be on schedule.
I'm just saying, it was just ruled yesterday, 2 days ago.
2 days ago, okay.
Or last week, I guess. It is now a Schedule 5.
Oh, they did schedule as a problem.
Schedule is Schedule 5.
I'm surprised.
Robitussin AC.
Oh, okay.
And that's the federal level, right?
Yeah, that's at the DEA, yeah.
Same as Robitussin.
Robitussin AC.
Or
Which has
Lyrica.
codeine.
Yeah, or like Lyrica, which is like gabapentin, but a stronger version of gabapentin. So, yeah, so if you look at the prescriber information for this medication, they do all the same studies that they do for all the other medications like dronabinol and benzos and opiates, where they give this substance to people who use recreational drugs or history of addiction, and they ask them to say, do you like it? Do you feel high from it? And everybody said no. So I think most people expected that it was going to be on schedule. So I'm surprised. I have to look more at that. So there's another cannabinoid-based medication that's being examined by the FDA, and that's Sativex. That is 50-50 THC and CBD 1-to-1 ratio. So exactly the same dose. It is approved in lots of other countries, in Europe, in Canada, United Kingdom, but it's still being examined in the US. And its indication in all the other countries is for multiple sclerosis. So this will make a fifth drug once, hopefully, it will get approved. So what all these medications have in common is they've all gone through standard FDA trials. So before medications are approved, FDA requires what they call phase 3 clinical trials, large trials. FDA has specific criteria that the manufacturers have to meet in designing the trials. Placebo control is important, double-blinded, and based on these trials, they assess both the benefits and the risks, all the side effects, drug interactions, other medications. For example, turned out that not only were there drug interactions with CBD, but also there was concern with liver toxicity. So liver has to be monitored in patients taking that medication. All right, so that's what the FDA is doing. I'm going to show you what this stuff looks like. So this is Marinol. So this is THC. Just it's made in the lab. This is Nabilone. This is Schedule 2. This is THC-like, but more potent. Okay. This is the one that was just approved. This is CBD. And I don't have pictures of the one that has not been approved. All right, so we're going to move on. And I'm going to talk about the whole science behind this. So what are we all talking about here? What are cannabinoids? So cannabinoids are substances that work on the cannabinoid system in the brain. That's how we're classifying these things. So the endocannabinoids are things that we make endogenously inside our brains. This is, think about the opiate system in our brains. So the opiate receptors and our own endorphins, right? Why do we have opiate receptors? For our endorphins, okay? So why do we have cannabinoid receptors? For our own endogenous cannabinoids, our endocannabinoids. 2-AG and anandamide, our own endogenous cannabinoids. Our own endogenous cannabinoids, just like endorphins, regulate our opiate system in the brain. The endogenous cannabinoid regulate our cannabinoid system. There are also phytocannabinoids, so these are plant-derived cannabinoids. So THC and CBD are both plant-derived. So marinol is a synthetic cannabinoid. So is nabilone. The recent CBD approved by the FDA, that was plant-derived. That CBD that's now FDA approved for seizures in children was derived from the plant. And Sativax, the substance that's approved in all the countries for multiple sclerosis, but not in the US, it's also plant-derived. Both the THC compound and the CBD compound in Sativax is derived from the plant. So, all right, so that's different ways of understanding what we're talking about. So what's the difference between THC and CBD? So THC is to say it bluntly, is the addictive part of marijuana. It causes euphoria. We blame THC for impaired cognition, so when we worry about DUIs. Addiction, craving, withdrawal is associated with THC. Psychosis is associated with THC. CBD is actually associated with blocking psychosis. And so if you have the right mixture of THC and CBD, in theory, you should be able to protect the patient from psychosis when you give them a little bit of THC. THC is also associated with worsening anxiety and mood symptoms. We think about a lot of anxiety and depression. And whereas CBD is used to treat anxiety. The nice thing about THC is the anti-nausea effect, improved appetite, and possible pain relief, although pain relief is probably a combination of both THC and CBD. What is CBD? Well, there's no high with the CBD, at least in the studies that we've done so far. We think it's pretty safe. We think there's no significant impact on cognition. There's no association with psychosis or addiction, we think. We don't have absolute proof of this. The way it works is it inhibits the degradation of our own natural endocannabinoids. So imagine taking a medicine that will give you more endorphins, right? So it's the same kind of thing. CBD keeps your own endogenous cannabinoids at a higher level. And it also works directly on serotonin receptors. We think this is associated with the antipsychotic and anxiolytic effect. You're thinking serotonin, antipsychotic, yeah, because if you think about all the new atypical medications that we've been using, the atypical antipsychotics, they all have a serotonin mechanism. That's what makes them different. And they're using this receptor. And so it may also reduce anxiety. We have 1 or 2 studies showing this, but the dose has to be pretty high. And this is also the dose that you would have to get an antipsychotic effect. So if you look at that bottle that I showed you earlier, I'm just gonna go back. So 1 milliliter is 100 milligrams, so a patient would have to take about 8 milliliters a day, 8 to 10 milliliters a day. It's a lot to get an anxiolytic or antipsychotic effect. Okay. So, and then you have to be careful with the liver when you're giving that much. Okay, so how do people administer marijuana? So now we're talking about marijuana. So marijuana is really the plant, but we have interchangeably used marijuana to mean cannabis, so anything that contains a product of the marijuana plant. But typically, people will smoke it, vaporize it, or eat it. And there are 66 cannabinoids in the marijuana plant. There are probably 400 compounds in the plant. 66 of these are cannabinoids. And today we're just understanding THC and CBD, 2 of the 66. Okay, so that's what we've been talking about. So again, THC is the main psychoactive cannabinoid, and CBD may be actually an antagonist to some of the effects of THC. So plants, when you talk about plant-derived cannabinoids, what kind of plants are out there? So there are different kinds of plants. So just like the tobacco industry can breed plants to have different amounts of nicotine, the marijuana growers can breed plants to have different amounts of THC and CBD. So they have the THC type, which has very little CBD and a lot more THC, up to 15%. A hybrid, which is about 50-50, primarily CBD type plant, which is very low in THC and has much higher CBD amounts. But what is important to note is the THC predominant strains can yield more than 25% THC. And this is actually one of the problems that I've been reading about in the Netherlands. They have, and I'll show you later slides, their main reason that people are asking for treatment is marijuana addiction. And the marijuana plant that's being sold is very high concentration. So they're trying to solve the problem by keeping the marijuana legal, but keeping it 15% or lower. So the endocannabinoid system. I've been saying that a lot, the endocannabinoid system. So this is our own natural brain system. So there are two receptors that we've been studying the most. We think there are more, but these are the ones that we've been studying the most. The CB1 receptor is in the brain, and the CB2 receptor is in the immune system. And this is why people are looking at marijuana or cannabinoid products for treatment of immune conditions, including cancer. So THC binding to CB1 is primarily responsible for the abuse-related effects of cannabinoids. CB1 is located throughout the human brain, highest concentrations in the hippocampus memory center, the neocortex, that's our adult advanced brain, the basal ganglia, this is where the Parkinson's research lives, and the cerebellum, this is where we have trouble driving, when this is like alcohol. Also in the amygdala, and the hypothalamus. And this is one of the reasons that we're looking at things like PTSD and even addiction, right? So, okay, so just to show you the brain, what are we talking about? So the amygdala is the emotion, fear, anxiety experience, and the amygdala is right here. So we think of that with anxiety disorders, PTSD. It's also an important component of craving, drug cravings. So, so THC can induce panic or paranoia in the amygdala. Basal ganglia has to do with movement, so it can slow reaction time. In the brainstem, THC can create the anti-nausea effect. In the cerebellum, THC can impair coordination. Hippocampus, this is where THC can impair memory, so we have studies showing that. In the hypothalamus, it can increase appetite. Neocortex is complex thinking, and that's this whole, upper part of the brain, our sort of modern brain. So altered thinking, judgment. The nucleus accumbens is euphoria, the feeling good, also associated with addiction. And in the spinal cord is where THC affects the altered pain perception. This is how THC can reduce pain. Okay, so, all right, so I want to take a step back. And we talked about the science. Now I want to move into the clinical piece. Okay, so what do we do with the science? What do we know, and what are we putting into practice? So I'm going to go back to Canada because the College of Family Physicians of Canada in September 2014 was dealing with their medical marijuana laws. And they were authorized to recommend dried cannabis for chronic pain and anxiety. And so the College of Family Physicians issued guidelines, practice guidelines to their members. What do you do with this? So this is what they said. Dried cannabis differs from prescribed products in that Health Canada, that's their version of the FDA, has not reviewed data on its safety or effectiveness, and has not approved it for therapeutic use. This situation puts family physicians in a difficult position. We're asked to authorize our patients access to a product with little evidence to support its use, and in the absence of regulatory oversight and approval. So their guidelines were just very common sense guidelines. They said that we know that cannabis is a potent psychoactive substance. It can have acute and chronic cognitive effects. We talked about memory and thinking. Perceptual distortions, cognitive impairment, euphoria, and anxiety. Chronic use of cannabis can be associated with persistent neuropsychological deficits, even after a period of absence. The patient may report initial benefit from smoking cannabis, as with many mood-altering substances, such as alcohol, opiates, benzodiazepines, and cocaine, experience temporary relief from pain or anxiety. However, these products have the potential to cause harm by impairing memory, worsening performance at work and school, interfering with social relationships. Basically, they're talking about addiction. So they're saying before authorizing, you have to consider if there's sufficient evidence that the anticipated therapeutic benefit for the patient, especially their health condition, will outweigh the potential harms. It's up to the doctor to weigh that. Similarly, continuing cannabis is warranted only if the physician is satisfied that there's been improvement in the patient's pain level, function, quality of life, and then there's no sign that the patient is at risk for misuse or harm. So they're saying the doctor has to be constantly assessing the risks and benefits. So general recommendation that went out at that point was to only make recommendations for neuropathic pain, because there was really no evidence that it worked for anything else. And you have to first make sure that you've given adequate trials of other pharmacologic and non-pharmacologic therapies. And also adequate trials of pharmaceutical cannabinoids. So this would be nabilone, dronabinol. Okay? So cannabis is not appropriate for anxiety or insomnia. They basically say there's not enough evidence, you shouldn't be recommending that. And they said it's also not appropriate for patients who are under the age of 25, personal history or strong family history of psychosis, current or past cannabis use disorder, active substance use disorder, any kind, heart disease, respiratory disease, or pregnant or planning to become pregnant or breastfeeding. Okay, so those are just basic sort of recommendations. Now, assessment and monitoring. So they're basically saying if you think your patient has some kind of mood disorder, like depression or bipolar disorder or anxiety disorder, or they're a smoker, or they have a high risk of heart disease, or they're heavy users. So these are not patients who have addictions, but they're heavy users. You should really be very cautious with these patients. Misuse prevention intervention. Monitor all patients on cannabis therapy for potential misuse or abuse. This is kind of how we treat opiates now. Before signing a medical document authorizing dry cannabis for pain, the physician should do all the following: pain assessment, assess for anxiety mood disorder, screen and assess for substance use disorders, and you should regularly monitor the patient's response to treatment, including patient's function and quality of life, in addition to pain relief. And the therapy should be discontinued if there's not clearly effective, if it's not clearly effective or is causing some kind of harm. And preventing harm. They gave specific recommendations to advise patients not to drive at least 4 hours after inhalation, 6 hours after oral ingestion, 8 hours after inhalation or oral ingestion if you feel euphoria. There should be harm reduction strategies advised to the patient at that point. And there should be clear communication with other providers. So any disagreements with patients about decisions around dosing, should be met with clear, unambiguous, evidence-based statements. This is what we know, this is what we don't know, this is why we're not going to do X because we don't know anything about it. The physician who's authorizing cannabis must be primarily responsible for managing the care of that condition. And if you have a second opinion person involved, you have to make sure that you're working very closely with a specialist. So, for example, if you're recommending in Pennsylvania cannabis, medical marijuana for PTSD, you got to be the main provider who's going to be providing treatment for PTSD. This would be a comparable example. So, dosing. Given the weak evidence for benefit and the known risk of using cannabis, the only sensible advice for physicians involved in authorizing cannabis: start low, go slow. And there in Canada, they're telling their family physicians, you have to specify the percentage of THC on the medical document. And they had a specific cutoff. It should never be above 70%. That was their cutoff. So how do we know in the United States what to recommend? Because we're not in Canada. We don't have something as wonderful as that. So how do we know? Well, so I had the pleasure and the honor as part of the work that I did with the Philadelphia Psychiatric Society and the Pennsylvania Medical Society to serve on the physician board that was working with Dr. Levin to help implement the medical marijuana laws. And my understanding is that Dr. Levin's position in those talks was that she wanted to leave it up to the doctor and the patient. She didn't want to interfere in the doctor-patient relationship. So she wanted to make this product available and let the doctors and patients decide what was best for their care. Kind of hands-off, clinician will figure it out if you give them the information. So how do clinicians know what to recommend? Well, typically we use practice guidelines. So what I showed you was the Canadian practice guideline that they issued for their family physicians. So right now, I'm going to talk about the 4 serious medical conditions that are covered under Act 16 in Pennsylvania that most overlap with the psychiatric practice. There are a lot of them, but these are the ones that I think we will likely see most in psychiatry. So the practice guidelines for autism, anybody who wants to find these, the CDC and NIH have reference guidelines for evaluation, treatment of autism, which include early intervention services, comprehensive behavioral interventions, and various medications that are FDA approved, not for treatment of autism, for other disorders that have some benefit in autism. The practice guidelines for autism do not include the use of cannabis or cannabinoid compounds. Practice guidelines for PTSD. This is one of the times where the American Psychiatric Association and the American Psychological Association have basically the same exact guidelines for the evaluation and treatment of PTSD, which include a combination of cognitive behavioral therapies and medications. And we do have specific FDA-approved medication for treatment of PTSD. Sertraline is all to be one example. Practice guidelines for dementia. So that's the American Academy of Neurology. They have guidelines for evaluation and treatment of dementia, which include a combination of behavioral and environmental interventions and medications, which include cholinesterase inhibitors and vitamin E. Antipsychotics are effective for agitation or psychosis in patients with dementia, where environmental manipulation fails, and antidepressants are effective in depressed patients with dementia. Okay, so those are standard guidelines. What are they based on? So they're based on large placebo-controlled double-blind trials of various therapies, environmental interventions, early intervention studies for autism, and medications. And when enough studies are replicated, looking at the same treatment from different directions, then it gets adopted into a practice guidelines. So that's how we do it. And the last one is the opiate use disorder practice guidelines. Since I thought this was interesting because the Canadian guidelines, this is their like version of NIDA or NIH, and the ASAM, American Society of Addiction Medicine, the national practice guidelines for treatment of opiate use are basically the same. It's just Canadians look very, very concise, so I use the Canadian one. But it's basically, ASAM has this in like 100 pages, and can I just put it like they just put it in one tab? So basically, this is 100 pages of ASAM. So basically, it is in opiate agonist treatment. We call it medication-assisted treatment. They call it opiate agonist treatment, but that's basically what it is. Bupe and methadone here. And they're basically saying that the quality of evidence is high, that you should initiate opiate agonist treatment with either buprenorphine or methadone, and they both have high evidence. Individuals with a successful and sustained response to methadone who express a desire to have transition to Suboxone is probably okay to do, and that's moderate evidence. So the highest evidence is for opiate. That's the practice guideline. That is basically the same. And you can think of it as international because it's in both countries. So let's talk a little bit more about practice guidelines. So we look at all the studies that we've done so far using cannabinoids because the question came up somewhere around 2014, 2015. Have we done enough studies to see if we could develop a practice guideline that would include cannabinoids? So this is a study cited by many researchers. It was a meta-analysis. So Whiting and his group published in JAMA, the Journal of American Medical Association. It's their leading journal in 2015. And this study plus some additional research was also done by Dr. Andrade in 2016. So this is an updated version of Whiting. And that was published in the Journal of Clinical Psychiatry. And basically, if you try to put some kind of treatment guidelines together for cannabinoids, this is what we have. So there are randomized controlled trials for cannabinoids. There were 79 randomized controlled trials. So that means placebo-controlled. Only 2 of those evaluated cannabis, the actual plant. The rest, 77 were primarily dronabinol, or nabilone, or Sativax. They were pharmaceutical cannabinoids. So in these trials, cannabinoids were superior to placebo for relief of chemotherapy-related nausea and vomiting. We kind of already knew that because it's already FDA approved for that. It's also superior, cannabinoids also superior for reduction of pain, although narrowly missed statistical significance. So they're talking about different ways of measuring pain outcomes, and it's not clear that it's convincing enough that it's really better than other treatments. Other places that cannabinoids have been examined, increased weight in patients with HIV and AIDS, there were 4 studies. Improved sleep in patients with sleep disorders, 2 studies. Severity of tics and interest disorder, 2 studies. Total patients, 36 patient studies. That's how many patients there were. The benefits were mostly inconsistent. Quality of evidence was deemed to be low. And what little evidence is available was not encouraging. That cannabinoids or anxiety, that cannabinoids are helpful for anxiety or depression. So that was 2015, 2016. In 2017, oh, sorry, this is PTSD. Okay, I'm going to shift to PTSD. Around the same time, in 2015, this was a study published looking at marijuana and PTSD. So in this study, they had looked at records of over 2,000 patients, veterans in the VA system. And they classified these patients with PTSD in patients who never used marijuana and people who used marijuana. And the bottom line is they found that when compared to with people who stopped marijuana or never used marijuana, marijuana use was associated with worse outcomes in PTSD, violent behavior, measures of alcohol and drug use. At follow-up, those who stopped marijuana use during treatment or never used marijuana had lower levels of PTSD symptoms. And those who started marijuana during treatment had highest levels of violent behavior. After adjusting for other covariates, starting marijuana use had an effect size on PTSD symptoms of positive 0.34, and stopping marijuana had an effect size of negative 0.18. So basically, these are thousands of vets who had PTSD treated in the VA system. And if you stopped marijuana use or never used marijuana while you were getting treatment for PTSD, you had better outcomes. If you started using marijuana or you continued using marijuana as you got treatment for PTSD, you had worse outcomes. So this is a direct, large study. It's around the same time that we don't have a lot of evidence that marijuana actually works for PTSD. So what is the PTSD story? How is it becoming something that we're recommending marijuana for? Well, so there's a lot of basic science behind PTSD and the cannabinoid system, the endocannabinoid system. So there is dense expression of the CB1 receptor in the amygdala, the hippocampus, and these circuits have a role to play in anxiety, emotional learning, consolidation of fear-related memories, coordination of fear-related behaviors. So these are all PTSD symptoms. So the cannabinoid system plays a role in symptoms that have to do with PTSD. So we think that the cannabinoid system mediates the retrieval of fear-related memories, and so maybe there's a potential biological substrate for the therapeutic effect of cannabinoids in PTSD. That's the basic science. We think there may be. So we're doing animal studies, and animal studies actually look pretty good. If you have little mice running around who have a model of PTSD, and we give them cannabinoids, they seem to do better. We have one study where we give nabilone to PTSD patients, a small study, and we suppress their nightmares. So this is all promising, right? But we don't have large the kind of clinical trials that you want, where you can replicate the effect, placebo-controlled, with smoked marijuana, in showing that it actually helps PTSD. So we have basic science, and now we're jumping way ahead and recommending something that really is not based on sufficient clinical research. And that's the real concern. So what's the other story? So this is a study that was published. CBD was shown to be helpful as adjunctive therapy in schizophrenia. It was just published last year. This is a British group. This was published in the Green Journal, our biggest journal in psychiatry. British group, most of the patients were from Romania or Poland. 15 patients were from England. None of the patients were in the US. They were using CBD, doses of around 10 ml, so like 1,000 milligrams per day, in addition to their antipsychotic. And in this one study that has not been replicated, the patients benefited. So there were 40 patients who received treatment, and it's just like a really small study, and it's not enough to start recommending that we give this to everyone. The other story with opiates. So there was an article published, I think in 2017, saying that when they examined data in 2014 in Colorado, the opiate death rate had really fallen. And that correlated with legalization of recreational marijuana in Colorado. Well, this is the Colorado Department of Public Health and Environment. So 959 deaths in 2017, 16 deaths per 1,000, 83% increase from 2001. 2017 has an 83% increase in deaths from 2001. So these are the deaths. Opiate versus non-opiate. So the opiate death rate is still climbing, and the total death rate is very high. So this is this is April 2018, Denver Post, opiate deaths, an all-time high in Colorado. So here's 2014, so there's a little bit of a downturn right here, just that 1 year, right back up. So the problem is you can't just look at 1 year, because yeah, look at that, that's what that look. So meanwhile, heroin, methamphetamine, and if you take that total, the death rate's just going down. Okay. So Colorado was not saved by marijuana, unfortunately. Okay, so coming back to the question of, well, maybe if we give cannabis to people with chronic non-cancer pain or on opiates, they won't use as many opiates, or they will feel better. It'll enhance the effect of opiates and give them more pain control. So this is out of Australia, published in Lancet just in 2018. Over 1,000 participants in this study. And this was a follow-up, about a 2-year follow-up. And, oh no, sorry, it's a 4-year follow-up. So there were 24% of these patients who used both opiates and marijuana. Cannabis use was common in people with chronic non-cancer pain who had been prescribed opiates, but we found no evidence that cannabis use improved patient outcomes. People who used cannabis had greater pain and lower self-efficacy in managing pain. There was no evidence that cannabis use reduced pain, severity, or exerted an opiate-sparing effect. So, meaning if you smoke cannabis, you did not use less opiates. As cannabis use for medicinal purposes increases globally, it is important that large, well-designed clinical trials, which include people with complex comorbidities, are conducted to determine the efficacy of cannabis for chronic non-cancer pain. We still don't know, like just because it works in the lab doesn't mean this is actually clinically effective. And this is out of Canada in 2017. Impact of cannabis use on patients enrolled in opiate agonist therapy in Ontario, Canada. Canadian government legalizing cannabis in the year 2018. Potential harms to certain populations, including those with opiate use disorder. So they did a retrospective cohort study. They looked back, looked at 58 clinics that were offering opiate agonist treatment to Canadians. And they talked about treatment retention, but basically they had 644 patients, 328 of which were considered baseline cannabis users, and 256 considered heavy users. So patients with baseline cannabis use and heavy cannabis use were increased risk of dropout. And you know, if you drop out of opiate agonist treatment, you don't do well, right? So that our first goal is in opiate agonist treatment is retention. These patients did not stay in treatment. What are you going to do, right? You have an effective treatment, high level of evidence that it's going to work. They don't stay. You give them pot, they don't stay. When evaluating these trends by gender, only female baseline users and male heavy users are increased risk of premature dropout. So women who are coming in with marijuana on board and men who are heavy users. Baseline and heavy cannabis use predict decreased treatment retention. So if you're running a clinic, and I was trained at the VA methadone clinic, we wanted no marijuana in that urine. If you wanted to stay on methadone, we wanted no marijuana in that urine. And this is why, and that was like 20 years ago. So, like, we've known this. This is not news. So adverse events associated with cannabinoids. So going back to the clinical trials that we've done. So overall, when you give cannabinoids to patients, they do have side effects. Now, mind you, I said most of these studies were done with dronabinol and nabilone and Sativex. Very few were done with smoked marijuana. So these are side effects of dronabinol, nabilone, Sativex. Okay? So mostly you get dizziness, dry mouth, nausea, fatigue, somnolence, euphoria, vomiting, diarrhea, disorientation. But dronabinol is basically THC, so those are the side effects of THC. Sativex is a combination of THC and CBD. So there are side effects. Now, in 2017, National Academy of Sciences in the US conducted their own analysis of all the studies. Again, we're looking at practice guidelines. What can we tell physicians is safe to do? Okay? So they actually looked at Whiting. That's the original one that I told you about from 2015. And they added their own analysis. And they said, you know what, there is substantial evidence that cannabis is an effective treatment for chronic pain in adults. They said only a handful of studies have evaluated the use of cannabis in the United States. All of them evaluated cannabis in flower form provided by the National Institute of Drug Abuse. That was either vaporized or smoked. Now, we actually used the same thing in our marijuana addiction trials. And that tends to have a constant, you can actually ask for placebo marijuana if you want, so it can have close to 0 THC in it. And you can have 3%, you can have 6%, you can have 7%. I don't think they go above 7%. So this is low percent THC. In contrast, many of the cannabis products that are sold in state-regulated markets bear little resemblance to the products that are available for research at the federal level. So for example, they're saying, in 2015, there were all these units of edibles that were sold. Like, no one did any studies on that. That's never been studied. So they're basically recommending that we don't give patients advice on using products that have not been tested. That's the basic. So yes, cannabinoids may be able to help with pain, but before you're going to recommend something, you should really know what the patient's going to get. What else did they find? So this is National Academy of Sciences, again, reviewing all the evidence, trying to develop practice guidelines. There is conclusive or substantial evidence that cannabis or cannabinoids are effective for treatment of chronic pain in adults, antiemetic, chemotherapy-induced nausea, and improving patient-reported multiple sclerosis spasticity symptoms. So this is oral. This is oral. And this is cannabis, so they're including the smoked cannabis that was tested in the NIDA-provided cannabis. There is limited evidence that cannabis or cannabinoids are effective for increasing appetite, improving clinical measure. So this is saying patient-reported improvement, clinician measured. So patients say they feel better, but there's not as much evidence that clinicians think that the patients are doing better. Limited evidence that improves Tourette's. So this was dronabinol, improving anxiety symptoms. There was one study looking at cannabidiol, CBD, and PTSD. This is the nabilone study, a single small fair quality trial using nabilone in PTSD patients. So dementia, limited evidence that cannabis or cannabinoids are effective for improving symptoms associated with dementia. Reducing depressive symptoms, individuals with chronic pain. This is Sativex, dronabinol, and nabilone. No or insufficient evidence to support or refute the conclusion that cannabis or cannabinoids are an effective treatment for achieving abstinence in the use of addictive substances. There's just like no evidence. So, okay. We worry that there may be some negative health effects like triggering an MI, stroke, hemorrhage, increased risk of prediabetes, COPD, because you're smoking, also worse respiratory symptoms and more frequent chronic bronchitis, again, smoking. Pregnancy, overdose in children, low birth weight in the offspring. So we don't know what the effects are, later outcomes in life. So if a mother smokes during pregnancy, if she smokes or uses cannabis during pregnancy, lower birth weight in her baby, but the long-term cognitive, academic achievement, all that, we don't know. And children, if they're consuming edibles, just like children taking Suboxone accidentally, overdose risk. Okay. DUI and cannabis. Okay, so Canada did a lot of this, but basically we have clear measures that can be done in the blood, THC in the blood, serum THC concentrations. And this is kind of comparable to the alcohol levels in the blood. So, so if your level in the blood is between 2 and 5, there's significant shift towards impairment. At concentrations between 5 and 10, 75 to 90% of the observations while you're in a driving simulator were indicative of impairment. And once you get above 30, you're like 100% impaired. So the upper, they established the lower and upper range, somewhere between 2 and 5 should be the range where we want our patients, preferably 0, but it could be something like, 5 would be comparable to blood alcohol level like 0.8. But for like professional drivers, you might keep it down to like 2. But bus drivers, you don't want them at 5. School bus drivers, you probably want them below 2. Okay. All right, so moving into looking at addiction. How am I doing on time?
You're doing great. You have
Okay.
about 20 minutes
Okay.
before the break.
This is the last section. We talk about addiction and addiction treatment. Questions up to this point? You guys are following along? Yes.
Did you mention any correlation with lung cancer with the smoking or not?
Lung cancer. Unclear. Yeah. So National Academies of Press, if you guys Google National Academies of Press, National Academy of Sciences Press, their summary, their 2017 summary, it's free, it's a PDF, and they go through all of that. It's like a reference dictionary. You go by disorder, and they give you all the studies. And it's unclear. There's not enough evidence.
So it's not completely comparable then to just regular cigarettes?
No,
We're not looking
no.
at-
And it may be that we don't have enough evidence, we just haven't studied it. Yeah. There's a lot of concern about that. So I'm going to show you the addiction story. I'm going to start back in the Netherlands. And the reason I'm starting back in the Netherlands is when I was starting my marijuana addiction treatment study at Penn, every year the addiction psychiatrists have a meeting. We all get together in December and say, okay, what's going on? What are we working on? What are the big problems? What are the solutions? And all the main centers and the fellowships all get together. And I was presenting that we were starting the study at Penn, and a colleague from Netherlands came up to me and said, as soon as you have a treatment, let me know. So this is 2005. Let me know, because we have the biggest problem that we have nothing to help our patients with. I'm like, what do you mean it's a problem? It's like legal. She's like, yeah, doesn't mean it's not addictive. I didn't know what I was doing. I was just starting to study. So she sat me down. She said, look, it's really addictive. This stuff is really addictive. People start smoking recreationally, and then they come to me and they say, get me off. I can't come off. I want to stop and I can't. And they describe all this. Now, this is 2005. In, I think, 2009, 2010, I took my addiction boards in the US. And on that exam, even though I've been studying marijuana addiction, I still had the correct answer to the question, which of these substances is not addictive, was marijuana.
Wow.
Because the DSM-4 was still not listing it as an addiction. So I had to get the question right. But so I wasn't that far behind the time, but the Netherlands were ahead of us. This was also around the same time that they started experimenting with medically prescribed heroin to treat their opiate epidemic. But anyway, so that's why I'm going back to the Netherlands. So this is what was going on in the Netherlands. So cannabis. Okay, so I think the colors came kind of through okay. So you see this is the cannabis band. See it expanding? 2004 to 2013. Look at the growth. Huge, right? Percentage of opiate clients decreased. Opiates went down. And cannabis clients steadily increased from 25% in 2004 to 49% in 2013. Clients seeking treatment. Now, Netherlands, everything's free. All addiction treatment is free. You want it, you get it. Whatever you need, they provide. So they're tracking all their citizens. Everybody's in treatment, and they doubled. What did that correlate with? Well, it probably correlated with this. This is what was going on in the US. This is 2004, and this is 2012. Potency of THC went from about 6%, which is kind of like NIDA grade marijuana. This is what NIDA gives you if you want to do marijuana research. To 12%, it doubled. So as the potency of THC doubles, so does the addiction potential of it. So this is 2017 report from Netherlands. So this is cannabis. In 2017, if you look at all the treatment entrants, all people who entered treatment for drug addiction, 47% were seeking treatment for cannabis, 24% were seeking treatment for cocaine, 8% for amphetamines, heroin was 9%. So that's what's going on in the Netherlands. Now, they've had legal cannabis, like if you're a resident and you have a resident card, you go to a coffee shop, you want to smoke, you can smoke. Legalized, not medicalized, but legalized. Okay. So coming back to some of the adverse health effects, just to summarize. So we're going to focus on marijuana addiction, but just to also talk about why we worry about our adolescents. So diminished life achievement, motor vehicle accidents, chronic bronchitis I mentioned, abnormal brain development, progression to other drugs, schizophrenia, depression, and anxiety. These are things we worry about with marijuana use. So acute effects of cannabis intoxication. So if you smoke right away and you get intoxicated, you will experience euphoria, maybe anxiety, altered perception of time gets slow, impaired judgment, poor coordination, reaction time, increased appetite, dry mouth, tachycardia, your eyes will get all red. So any one of these and two of these will give you cannabis intoxication. So if you have euphoria plus increased appetite and dry mouth, you will qualify for cannabis intoxication. All right, so what happens with short-term marijuana use? Well, impaired short-term memory, study for a test, DUI potentially, high-risk sexual behavior, paranoia, psychosis, but really only in high doses. This is the most common thing I hear about patients. I had a bad trip. No. Okay. So frequency and duration of use directly impacts the risk of chronic effects. So the way I think about it when I see marijuana addicted patients is I think of them in kind of three categories. So naive users or healthy controls. So I include in that patients or people who say that they've used cannabis less than 15 times in their lifetime. This is somebody who's like, yeah, I tried it a couple times, I don't know, maybe in college I smoked it 5 times. They're really controls. They're not, okay. Recreational or occasional users. So the way I think about it is less than 4 times a month. Right? This is like, having a drink with dinner when you go out with friends a couple times a month. It's kind of like that, right? So that's recreational use. It's possible to recreationally use marijuana. So chronic cannabis users. So these are people who are using cannabis several times a week, And in my mind, when I was doing the study, I was looking for people who used for at least a couple of years. But in clinical practice, what I've seen is if you're using marijuana 2-3 times a week chronically, so 6 months, a year, you might be already getting in trouble. It doesn't have to be 2 years. I think about the same way we think about alcohol, right? So if someone's drinking every night, 2 to 3 glasses a night, after 6 months, they're not sleeping so well without the alcohol, right? Their body's adjusted to it. So long-term or heavy marijuana use. So that's different than just using it recreation. This is long-term use or heavy marijuana use. So the endocannabinoid system, it's our own endogenous cannabinoid system, is involved in regulating adolescent brain remodeling. Let's go back to Prime Minister Trudeau at the very beginning, right? He was worried about kids in Canada, Canadian kids. So the endocannabinoid system is involved in regulating the brain development or brain remodeling. So what happens in adolescence? There's this big sort of blooming of neurons. All these new connections are being formed. They get, they're studying, they're getting into sports, they're developing friendships. That's actually helping their brain develop. And the endocannabinoid system is guiding that process. So when adolescents start using cannabis, their addiction rate is much higher. So if we think about 9% rate of addiction, 16% rate for alcohol, 9% for cannabis. In adolescents, it's 17%. They're more sensitive. Their endocannabinoid system is more sensitive. Now, overall, if you're looking at daily users of cannabis, their rate of addiction is anywhere between 25 and 50%. So if you start messing with the endocannabinoid system, you could end up with altered brain development. Usually if you start smoking adolescents. Poor educational outcome if you start smoking adolescents. Dropping out of school, cognitive impairment, lower IQ. This is for frequent users in adolescents. Everything in red is true for adolescents. Bronchitis, that's adults. Increased risk of chronic psychotic disorders, including schizophrenia. So exposure to marijuana at or before the age of 16 increases the risk of psychosis. So cannabis and psychiatric conditions. There's substantial evidence of a statistical association between cannabis use and development of schizophrenia or other psychosis, with the highest risk among the most frequent users. So this is the same organization that said there's substantial evidence that cannabis can help with pain, saying there's substantial evidence that it's associated with psychosis. There's moderate evidence of association between cannabis use and increased symptoms of mania and hypomania in individuals diagnosed with bipolar. This is for regular cannabis users. Small increased risk of development of depression. Increased incidence of suicidal ideation or suicide attempts. Higher incidence if you're a heavy user of cannabis. Increased incidence of suicide completion. That's not a surprise for anybody who studies addiction, right? Our co-occurring disorders, depression plus addiction, we think of these much higher risk patients, right, for the completion of suicide. Increased incidence of social anxiety disorder. I actually see this quite a lot. I have regular cannabis users and they're very socially avoidant. The impairment in the cognitive domains of learning, memory, and attention. So, coming back to adolescence, so if you look at risk of schizophrenia specifically during adolescence exposure, so if you have ever used cannabis, the risk of schizophrenia twofold. And frequent use of cannabis increases risk of schizophrenia sixfold. This is if you used it 16 or younger. Okay. And it decreases the age of onset of schizophrenia by 2 years. We think there's a genetic mediating factor, that it's not all adolescents, it's adolescents with a specific genotype that are more sensitive. And if you use cannabis after your first episode, associate it with poor prognosis. This is why one study done, with 40 patients who got CBD in addition to their antipsychotic, who improved their psychosis, is not enough to start recommending cannabis for all of our schizophrenic patients, right? Totally different. Cannabis use disorder, what does that actually mean? Well, actually forward to the, so this is what we're talking about. Just like any other use disorder, alcohol use disorder, cocaine use disorder, it's the same exact criteria. You're taking more of the substance longer than intended, lose control over your use, main focus of life becomes obtaining, using, or recovering from the substance, craving, failure in your obligations, you're using despite recurrent social interpersonal problems, and so on and so forth, tolerance, withdrawal. Mild, moderate, severe, depending on how many of these you have, 2 to 3 is mild, 4 to 5 is moderate, etc. So that's what it looks like. And people who are coming into our studies, they all had moderate to severe cannabis use disorders. They just couldn't stop. So what do we know about it? So increased cannabis use frequency. So the more you use it, the more likely you're going to progress to developing an addiction to it. So if we're recommending someone use cannabis 2 to 3 times a week for their pain, is that enough to start them on the road to becoming addicted to it? Because frequency is directly associated with the likelihood of addiction, just like anything else, any of our other addictive substances. Major depressive disorder is a risk for development of cannabis use disorder. Being male is a risk factor. Exposure to the combined use of abused drugs. So if you're already addicted to something else, you're a higher likelihood of becoming addicted to cannabis. And obviously during adolescence, we already talked about that. So persistence of cannabis use, and if you've had psychiatric treatment and you start using cannabis, you probably will have a harder time quitting cannabis. Problem cannabis use, and increased severity of PTSD. So our PTSD patients are more likely to develop problem cannabis use, just like they are more likely to develop problem alcohol use, problem benzodiazepine use, problem opiate use. So development of substance dependence and or substance abuse, including alcohol, tobacco, and other illicit drugs. So if you are using cannabis, you're more likely to also get addicted to other drugs. Okay, so this is what it looks like in the brain. Just want to show you, almost done. Okay, so what we did is we showed our cannabis addicted patients pictures of cannabis and pictures of random office supplies. And we alternated the marijuana cues with non-marijuana cues. And we took pictures of the brain. So when they were looking at marijuana cues, the addiction circuitry in the brain, this is the same addiction circuitry that we see for opiates, for alcohol, for nicotine, lit up. And then we asked them, how much were you craving? And there was a direct correlation between their craving marijuana and the lighting up of that circuitry. So we have a behavioral measure with a brain measure. That to us is pretty good evidence that we're looking at something real. Cannabis withdrawal. So all of these guys, the reason, and these were all guys because women's brains and male brains, we have to do imaging separately. So these were all guys. All of these guys were also, they were taking dronabinol because we were trying to get them through withdrawal, and we figured if they weren't withdrawal, then they would stop. So this is what withdrawal looks like. You have to at least 3 of the following symptoms within the week. My patients were telling me within 24 hours. This is why they kept smoking. This is what the colleague from Amsterdam was telling me. They can't stop. Because if they stop within 24 hours, irritability, anger, nervousness, anxiety, sleep difficulty, decreased appetite, restlessness, depressed mood, And women tend to have a lot more somatic symptoms, pain symptoms. So when my patients come in and say, I'm using marijuana for my anxiety, and I ask them, tell me about your anxiety, and they start to describe marijuana withdrawal. Like if I stop, if I don't smoke it for a day or two, I get really anxious, so then I have to keep smoking. I said, well, could that be withdrawal? Are you smoking marijuana for your marijuana withdrawal? So within 24 to 48 hours after last marijuana use, usually it's supposed to resolve within 10 to 14 days. My patients always yell at me when I tell them this. 2 months later, they're like, yeah, that wasn't 14 days. And in some cases, it can take longer. And usually, I mean, it really depends on patients. But so this is what we've used. Dronabinol, right? We've used that. This is Meg Haney. She's in New York, Columbia. They used nabilone, and actually that worked. Dronabinol didn't. This is NAC. The only problem with this is, though it worked in this study, it was never replicated. Now, what is NAC? It's like a vitamin. It's a nutraceutical. You get it at a store, no prescription. You have to worry a little bit if your patients have a history of asthma, but otherwise, it's like taking a multivitamin. So minimal side effects, a lot of research on NAC and anxiety disorders. So we know that it's probably equal to placebo from all of those trials. So I tell my patients, you can try this. If it doesn't work, it doesn't work. But we have one non-replicated, and I tell them exactly this, one non-replicated study. The problem with all of this is, and this is what we talked about in December of 2017 at the last AAAP meeting, we can get patients off marijuana for about 2 months. 6 months, if we're lucky. We can help them sleep. We can give them all of these sort of symptom management to help them sleep, to increase their appetite. We use mirtazapine to help them sleep and increase their appetite, keep them calm. But they have a high relapse rate. Within a year, 80% will relapse. And we don't have a treatment. We don't have a very good treatment. We can't keep them, so we can get them off, we can get them through the withdrawal, but it's really hard to get them to stop and maintain sobriety for longer than 6 months. So that's the problem. All right, I think it's almost 2:30. We have a couple minutes. Questions about any of this? And this last slide, I think this is a very nice website. It's by Washington State. When they legalized marijuana, they did a very good job funding the university to put together resources for adolescents and adults. It's a very good website.